I learned some of the things in endoscopy problem. You might be remember. Now I want to ask Rohan. See, Rohan, you are already having GI endoscopy room. Now you have got motility lab. What additional has come? What additional has come in it?
So, as we discussed, even Tantri sir said, on endoscopy, we can't diagnose all the diseases. Basically, those who are having difficulty in swallowing, motility disorders, basically related to the esophagus, anorectal region, which cannot be diagnosed either by your gastroscopy, colonoscopy, even CT scan, MRI. These facilities are not sufficient to diagnose this motility disorder. So these cases will be diagnosed with this GI motility lab with the use of manometry. Along with that, there are therapeutic options available. So somebody who is having defecatory disorder, which is diagnosed by anorectal manometry, we can treat it with biofeedback therapy, and that is the only treatment option available for such a patient. So these things like diagnostic.
In short, tell people what is biofeedback.
So in
short.
Yeah. So in defecatory disorder, what happens? The patient gets the urge to pass the stool, but they are not able to defecate it out. So the problem is in the dyssynergy between the muscles which are coordinating the process of defecation. So in biofeedback therapy, we teach the patient how to coordinate by showing the graph on the screen. So we tell them to squeeze. When they squeeze, we show the graph how their muscles are functioning. So once they see the muscles, how they are acting, they are able to coordinate. So even it is done for children also. So there are new softwares available. So they have made it like a video game. So there is a fish which is traveling in a water, and once they will squeeze, the fish goes out of the water. And then they realize how to squeeze. So you will squeeze more, the fish will go more up. So through the game, they teach us how to do coordination of the muscles, how to squeeze, how to push while doing the defecation. So this is called as biofeedback.
I have done suppose upper GI endoscopy, and it is normal or just lacks lower esophageal sphincter. Now, is this a patient to send for motility disorder?
So, if the patient's symptoms are explained by your endoscopy findings, there is no need of sending for motility testing. So, those patients, basically, as you asked for lax GE junction, those patients who are having hiatus hernia, and which is a large, that is grade 4, in that case, we suggest the surgical therapy as an option. So, before going ahead for the surgery, they should undergo this manometry test, because we should know that their esophagus is functioning well before going ahead for the lap fundoplication or surgical option for the treatment.
Which are other conditions where you do motility disorder or esophageal manometry?
So, one condition is difficulty in swallowing, where our endoscopy is normal, then there is no mechanical obstruction. So, we need to see for motility test. So, most commonly we see the achalasia cardia, where there is lower esophageal sphincter is not relaxing properly. Second is non-cardiac chest pain. We see a lot of patients who are coming with sudden chest pain, and that is after taking the food. If you do your angiography, stress test, everything is normal, your endoscopy is normal. In that case, we should subject them for this esophageal motility. Sometimes we see there is a problem in the motility. There are esophageal spasms. So esophagus is contracting excessively, leading to this type of chest pain. And third, for the lower GI, as we discussed, the defecatory disorders, where you are giving the laxatives, still the patient's constipation is not getting solved. And the typical thing, as I said, there is a urge to pass the stool, but they are not able to defecate it out. These tests are important.
Can I add one more condition for you? For example, patients who are refractory GERD, no? So we need to do 24-hour ambulatory pH monitoring. Prior to doing 24-hour ambulatory pH monitoring, we have to do a manometry. Firstly, to see where is the gastroesophageal junction, and secondly, sometimes there might be mimics, might be motility disorder which are mimicking as heartburn. So that has to be excluded. So that's another reason why we would like. And there is said that it's absolutely essential that surgeon should not do fundoplication without doing manometry. You need to see that esophageal peristalsis or clearing mechanism is normal. Otherwise, if you do fundoplication and esophagus is not working properly, the patient will be subjected to gas bloat or is unable to belch. These problems may happen.
Sir, I'll ask you. Suppose patient has large hiatus hernia, then manometry is required, or surgeon can do?
If it's a really large hiatus hernia, then manometry is just to make sure that the peristalsis is normal. He does require a surgery, so that if the major problem is the regurgitation, so that cannot be solved by giving proton pump inhibitors. We don't normally treat hiatus hernia as gastroenterologists. What we treat is reflux disease. So reflux can very well be treated by medical therapy. Proton pump inhibitors are excellent in controlling the symptom. The problem happens that heartburn will be controlled, but sometimes the problem is regurgitation. The moment they lie down, the food comes into the mouth. That cannot be taken care of by proton pump inhibitor. So for volume regurgitators, we do require surgery. So they require fundoplication. So before doing fundoplication, please do a manometry to make sure that the esophagus peristalsis is okay.
So how long PPIs can be given for GERD?
I've been taking for the last 20 years myself.
I hope Omud has heard that.
I take it for the last 20 years.
As a nephrologist, I would rather not take it beyond 6 weeks. 6 weeks is the ideal time period in which to take.
And then what do you do?
Then, if the patient is requiring longer than that, then you need to do your motility studies and do
The motility study will not solve the problem of reflux.
We have seen that there is increased incidence of CKD studies.
Yeah, I know. These are all associations, and the actual absolute number of cases which happen are very small. The odds ratio is very small of developing any serious nephropathy with long-term PPI therapy. As of now, all the guidelines in gastroenterology suggest that you can give long-term PPI therapy safely in all the patients who require it in the minimum possible dose, which is sufficient to control the symptom. The other option is lap fundoplication. There are problems with lap fundoplication. I am worried if the lap is too tight, I may not be able to bulge, and that is again a problem. If the surgery is not done properly, then you are gone, and nothing can be done.
Sir, what do you think about the meditation and yoga in this type of case?
No, sir, I know. I mean, that's very difficult. The behavioral therapy, or as well as the lifestyle modification, are very sounds very physiological and sounds very tempting. But the problem is that the patient who suffers from reflux will find that the benefit from this lifestyle modification is very mild to moderate. It won't control the symptoms properly. So unless until I take my dose of PPI,
Complementary.
it's only complementary, it helps only, but it won't control the symptoms. The quality of life suffers. The patient of reflux has a much poorer quality of life than a patient of untreated angina. So it is not an easy. You can say that PPIs are dangerous, don't take it. But then you ask them to stop it. They won't be able to eat anything. They won't be able to carry out their normal day-to-day life. The moment I don't take PPI, next day I'll have a constriction in my chest. I'll not be able to work. So that is the thing which you have to see. And how many of them actually go on to develop renal impairment? Very small percent. So this fear on the part of nephrologists is still unjustified.
Sir, prokinetic in GERD. Any value? Now you will answer.
Prokinetic, as I said, appears very physiological, that it will propel the food into the esophagus. It may tighten the lower esophageal sphincter. But what has been found is that the main mechanism of reflux disease is a phenomenon phenomena known as transient lower esophageal sphincter relaxation. What happens is that all of us have a pacemaker in the proximal part of the stomach. Now it allows the lower esophageal sphincter to relax intermittently. Normally it will only relax when the food goes down, but here the patient will difficulty to relax inappropriately for a long period of time when food is not there. That allows the acid to come. None of these motility drugs act on this transient lower esophageal sphincter relaxation, which is a dominant mechanism, except a drug known as baclofen. Baclofen is the only drug, but then that but that has very narrow therapeutic range, a lot of side effects, so we don't give it for a long period of time. Therefore, prokinetic adds about 10 to 15% over the BPI.
There are any endoscopic treatment for GERD.
Yeah. So that's coming up actually. People are trying to do strengthening of the lower esophageal sphincter, just like you can do fundoplication. We can also tighten the lower esophageal sphincter by the APC, or you can do endoscopic suturing also. So endoscopic fundoplications can be done. Right now, it's not the standard of care, but it can be done.
Now, you spoke about constipation, and what are common causes of constipation?
Constipation, basically two things. One is called as primary and second is secondary. Primary is basically a functional or idiopathic constipation, which is more common. Secondary comes with various reasons. One is with the drugs. Second is there are metabolic disorders like diabetes, hypothyroidism. Third is there is called as obstructive constipation. It comes because of tumor, polyp, or stricture, which is seen in Crohn's disease. So the secondary causes we see very rarely in a patient. Most common reason is a primary constipation. Primary, there are three types. One is called as normal transit, second is slow transit, and third is defecatory disorder. In that, what we see commonly is a normal transit constipation. So these people are having normal motility of their large intestine. So motions are coming with normal speed to lower down, but they are not able to defecate out. The reason we here we treat is basically change in their lifestyle. So increase in fiber intake, increase in water intake, daily exercise is required. These some modifications will do, the patient's constipation gets corrected. In slow transit, basically prokinetics are required. So there is one good drug now, prucalopride. It is safe enough and very effective, which we use along with the fibers or laxatives. And last, as we discussed, is a defecatory disorder. It is seen in hardly 20% of the patients with primary constipation, but this is important cause because here none of the laxatives are working. As in one patient who was suffering for 15 years with this defecatory disorder, and he has attempted several suicidal things also to end his life because he was not able to get cured from this problem. So these patients we should able to identify and we can diagnose with anorectal manometry, and the solution is available. The treatment is with biofeedback therapy.
There is one condition called as ODS, obstructive defecatory syndrome, and there are wide variety of treatment for that. I would like Dr. Tanvi to.
No, I mean that is a part of your defecatory disorder. So obstructive defecatory syndrome, or they also develop solitary rectal ulcer. Also, many of these patients, there's an anterior mucosal prolapse which comes and blocks the anal canal while patient is passing. So the anal canal is blocked. So again the treatment of choice would be what I said is a biofeedback therapy. We have done sometimes occasionally surgeons have done some surgical procedure for solitary rectal ulcer syndrome. But it's not very. The results are.
They do MRI deficogram for ODS.
Yeah, you can do. There are physiological testing which you can do apart from anorectal manometry. It's a part of anorectal manometry testing is a part of physiological testing where you can do so many things. MRI defecography. You can also do the colon transit study. You can do all this can be done to assess the functional constipation. What is that? Was functional constipation where endoscopy is normal, colonoscopy is normal, upper GI-scopy is normal. Then you have sometimes you may require this physiological testing before you take up the details.
But there is
One point I want to add. In the ODS, sometimes rectocele, vaginocele is there. On MRI difficography, we can correct with the surgery. Only one addition.
is sitting there. Any major surgery for ODS?
I mean, depending on the studies and what we
Yeah,
have,
suppose
MRI.
the epigography shows that there is intersection of rectum.
Correct. I mean, then we should assess the length of the sigmoid. Dr. Jagannath here, sir. I am a dental surgeon. Sorry. Yes. So, based on the studies we get, first we should assess the length of the redundant sigmoid the patient has, and then we come to know there is some interception because of the lengthy colon that the patient has. Best thing would be to resect that redundant part of the colon, do a rectopexy, which might solve. And in addition to that, if the sphincter mechanism is quite weak, I mean, if the patient has a very weak sphincter mechanism or a destroyed sphincter in an elderly situation, patient situation, then we can think about the local sphincter repair. If not, a thief stitch.
That's a fecal incontinence.
Yes, sir.
That's a fecal incontinence.
Fecal incontinence. So,
Have you heard of something like transanal resection of rectum?
yes, sir.
That is usually done.
Yes,
for this
yes,
purpose.
yes. I mean, once we
I
rule
have
out,
seen that procedure in workshop where they
use a stapling device,
Stapling
multiple
device.
levels of stapling, which we fire and resect the redundant
There's
mucosa.
something called a star procedure.
Start, yes,
Start.
start procedure. Yeah. And one more thing about this fundoplication, I just wanted to add. The recent consensus, what I have understood is, after doing an endoscopy and then doing a manometry, we do come to know that patient is going to need fundoplication. And manometry studies show that it's a very weak esophagus. So, doing all these studies, they are suggesting don't proceed with nascent fundoplication. So the consensus from dissents is shifting towards toupee. So they are always advising modified or a partial kind of fundoplication than doing a 360.
Yeah.
So that's going to prevent any kind of dysphagia which we are worried about. Because post-operative, that is the only concern, that dysphagia needs multiple attempts at endoscopy.
Yeah, that's fine. I mean, once you know that the esophageal peristalsis is weak, you can modify your fundoplication in such a way that it's not a tight wrap and then you make it a partial wrap or something like that.
Now, despite that, they are saying whatever the nature of the peristalsis or the contractions are, please stick to toupees. So, in that way, when are we thinking about just doing toupees all the time? If that is the consensus, then doing a manometry is in question. The consensus from whatever nascence, the routine nascence or a floppy nascence, they're saying you do whatever if the patient ends up with dysphagia.
I think it all depends upon doing a manometry will make you understand tomorrow he has some problem, then you can explain to him your peristalsis is weak, therefore you are having the problem.
Correct.
So beforehand only you can sort of counsel him that tomorrow you may have some trouble, so you have to bear it. So you give all the pros and cons. You take PPI therapy, the nephrologist has said that it will cause interstitial nephritis. He is worried, he is reading all magazines, PPI are so toxic, it can cause C. difficile infection, it can cause so many things. So therefore be aware of the long-term PPI therapy. But we give all the options to the patient. And then the patient has to select whether he wants to go for fundoplication. It's a good option. Or else he wants to go to long-term PPI therapy. He may require one of these two. Even not doing, there are so many patients who undergo fundoplication, but still they have to take PPI later on in their life. So it's not that all or none phenomenon. So may have fundoplication, less PPI in the coming years. So all these combinations are possible. But what I know is that PPIs have made gastroesophageal reflux disease management totally has changed this scenario. It was not so when H2 receptor antagonist was there. You cannot substitute PPI with H2 receptor antagonist. It doesn't work well. So patients who really require PPI, they may not need substitute.
And forbidden, my question is actually the last part, They said really require. because this really required many times is being loosely interpreted. I have two questions for you basically. One is a lot of co-prescription of PPI is being given along with an aspirin or an antibiotic, which is being promoted to the patient. This will cure a gastritis, and the patient continues it for a long time. Second is PPI a over-the-counter drug for patients to start using it as a gastritis pill? And we are completely not.
Agreed. I completely agree with that. For not only the gastroenterologist, everybody writes PPI, starting from surgeons or everybody. So the PPI misuse is quite common. It is quite often used for functional disorders of the GI tract, in which their role is quite sort of doubtful. Only few patients would respond to PPI, but their role in gastroesophageal reflux disease is unquestionable.